you, Colonel Rima, for the panel discussion. And if you could also let us know who the panelists are and what we're going to be discussing.
So is my screen visible?
Yes.
So thank you, sir, for taking over. We have some technical glitch, but we'll carry on with our panel. We understand that preeclampsia is something that has been troubling us with so many maternal deaths, and the conundrum of preeclampsia makes it an area of great controversy. And Society of Fetal Medicine, as always, observes these days to increase awareness. Let me first introduce my illustrious panelists. None other than Professor Ashok Khurana. Sir is the mastermind behind all our academic activities. Thank you, sir, for steering the wheel so well. Brigadier Navreet Singh is the senior most cardiologist of the Armed Forces, an alumni of the Armed Forces Medical College who's doing phenomenal work in the Armed Forces. Dr. Aparna Sharma, another dynamic fetal medicine specialist from the All India Institute of Medical Sciences and a dear friend. Dr. Charmila, who's you would be surprised to know that she belongs to Trichy, but she's also the secretary of the Gestosis Society. So she will give us a lot of information on the gestosis scoring. We have Dr. Apurva from Northeast. He's the president of the SFM Northeast chapter, and another young, dynamic fetal medicine specialist, Chinmay Umarji, who's the president of the SFM Greater Pune chapter. We welcome our panelists, and I'm sure they'll give us great information on preeclampsia. So we go on to our first case. This is a primary gravida. She came to us with no risk factors for preeclampsia. She was 31 years old, and when we took her history, her aneuploidy screen was low risk, and there was no maternal history suggestive of preeclampsia. My first question to Dr. Khurana is, sir, are you happy with this maternal history, or would you want to screen for preeclampsia, a young primary who comes to you?
Very simple. If we look at the incidence of preeclampsia in people who've had previous disease, we will miss out on most of the preeclampsia. We also understand that primaries have the condition. We also understand that we used to believe once that it doesn't happen in future pregnancies, but we've changed that around. And therefore, we cannot just use entry criteria such as name, age, sex for preeclampsia screening. We need to have a better method.
Thank you, sir. So what would you suggest would be the best method? You've discussed it, but just for the information of the audience, what factors would you take into consideration?
So you see, it's quite simple. If we were to take clinical characterization, then we do understand that with the ACOG guidelines, we would identify 10% of those patients that will have the disease. If we use the ACOG guidelines, we will have 40 to 50% detection rate. And that is really not enough because, our horoscopes and our astrologers can tell us better. And tossing a coin is 50% anyway. We need something that is close to 100% so that we can promise our patient that, look, if you are screen negative, you go home and you be peaceful in that pregnancy from this deadly disease. And if you're screen positive, you start this medication on time before 16 weeks, and it is extremely unlikely that you will ever develop the disease, and you and your baby will be safe.
Thank you so much, sir. So we want to do the epidemiological factors, but the uterine artery, the PLGF also is very important, and the mean arterial pressure to give us a detection rate of 90%. So now my next question is to Dr. Charmila. Would you start aspirin for this patient? Aspirin, yes, but I want to know that if you want to screen this patient in a low resource setting, would your screening be a little different before you, suppose she comes to you from a rural area, you don't have PLGF in your armamentarium, would you want to screen differently?
Yeah. Thank you, Dr. Rima, for those questions, and thank you for the coordination also. I'm sitting in Sri Lanka now, so I joined specifically because I know that I'll learn so much from this panel. As far as the screening for preeclampsia in a low resource setting is concerned, using the gestosis score seems to work because probably adding a uterine artery Doppler and PLGF will add more to the screening, but when you don't have those facilities, because even in a city like Trichy, we do not have the facility for PLGF, and it's quite expensive for our patients. So like instead of not doing anything, at least you should do the gestosis score, and you get an idea about how the patient is going to have a future in that pregnancy. And the other problem is many centers do not have the wherewithal to even refer a patient sometimes. So at least do something, and for that to start aspirin, you need something to base your treatment on. And the other point is, now we are doing lots of studies on just to the score in India and in Bangladesh also. In India, there were two important studies which said that it is useful for screening for preeclampsia, and that is a study by Dr. Meeta in Jammu, which she did in 2022, and she showed a high sensitivity and high specificity for this test. And the second publication which came was in 2024 by Dr. Sudhir in Gujarat, but he showed a lesser specificity, but still it's not bad. So doing a juxtaposed score, scoring the mother based on her maternal characteristics is useful for a setting where the other parameters may not be enough, not available.
Right. Thank you, Dr. Sharmila. But I think Dr. Khurana insists that we are not anymore an underdeveloped country. We need to do the combined preeclampsia screening for our patients.
Madam, I would disagree, because I'm in a very, very remote part of Tamil Nadu, and we have tried for access for PLGF, and it's not so available there. And regarding uterine Doppler, I always thought doing it at 20 to 24 weeks is much more useful to identify a higher risk for preeclampsia. Doing it at 11 to 13 weeks, when you should have actually started your aspirin, I don't know how much it will be useful. So just to score is quite good for us.
Right. So in rural areas, it does help you, right? So we did her biochemistry and we did her uterine flows. Her PLGF was low and her uterines were high. And when we did a risk calculation for preeclampsia, it was 1 in 87. This was based on maternal history, mean arterial pressure, uterine artery PI, and PLGF. So now the risk came out to be 1 in 87. Dr. Khurana, we've spoken about screening for twins. I would take this opportunity for singleton, but I would take this opportunity to ask you, will your screening for twins be similar? Would you want to do the PLGF for twin pregnancy?
You see, the situation is this, that we do screen in pregnancies. We do understand that screen positives would be much higher, and we would be actually treating a lot more patients. But it is still worth it, because we understand that the devastating effects in a twin pregnancy involve not 2 lives, but 3 lives. And therefore, it becomes necessary to try and work that out in this group of patients as well. So although the fact that we are actually have a much higher number of screen positive patients, it is still worth it.
Thank you so much, sir. Thank you. So, and of course now Chinmay is there with us. Chinmay, definitely now we know that now this patient deserves aspirin. You would start. So just to reiterate for everyone, what dose, what time, could you just, for the benefit of our audience?
Absolutely. So, Rima ma'am, I would agree with my previous speakers that we need good screening. And of course, here we have used the Mercedes-Benz model, meaning that we have looked at the demographics of the mother, we have looked at mean arterial pressure with uterine artery PI, and we have looked at biochemistry. So this has very good sensitivity with detection rate of 95%. And I would love to start aspirin for this lady. We have been toggling with the right dose and right timing of aspirin for more than 7 decades, until Aspirin came out and it said that the double dose. So for example, if you're in the American continent, then you, especially North America, you would want to give around 160 milligrams. And for rest of the world, around 150 milligram, at least more than 100 milligrams of aspirin given at the bedtime. As the slide says here, started at 12 weeks, anytime before 16 weeks, that is first proliferative phase of trophoblasts. The aspirin shows wonders. There is some benefit up to 19 or maybe even up to 22 weeks. But beyond 22 weeks, starting aspirin doesn't make much sense, because by that time your placenta has already developed and your aspirin is unable to change the way it behaves. So again, the second trimester screening takes a backseat here, because it could be more predictive in the absence of PLGF. With PLGF, first trimester is much better. Still, you would not benefit your patient much with aspirin. So you would want to give that dose, and at that time, at bedtime, up to 36 weeks.
Thank you, Chinmay, for those crisp inputs. So we have an 89% risk reduction in preeclampsia with this little drug aspirin. And if you look at this article that came way back in 1979, 2.5 milligram per kg dose is required to produce a consistent inhibition of platelet aggregation. And therefore, the dose that most of the people give of 75 is not adequate. There is a lot of resistance that happens with this drug if it's given at the dose, lesser doses. And with so many meta-analysis coming, none of the guidelines are still talking of 150 except the SOGC. So as Khurana sir says that they take time to understand, but yes, it's time for change. The dose has to be 150 for all of us. So our patient was non-compliant on aspirin, and she did develop preeclampsia with severe features. Her blood pressure was 180, 110 at 28 weeks. There was FGR, there was abruptio, emergency cesarean section, and delivered a 840-gram baby. Baby is in NICU. So aspirin could have really helped to prolong or even delay the development of preeclampsia in this patient, which, being non-compliant, really got us into trouble. We have Dr. Bhattacharya with us. Any other role of, say, calcium supplementation which can prevent preeclampsia? Dr. Bhattacharya? Your voice is a little low. If you could be a little louder. He has poor connectivity.
Calcium supplementation given by this can help prevent preeclampsia by increasing blood pressure and vascular function. And WHO issued a strong recommendation that pregnant women be provided calcium supplementation to prevent preeclampsia. This is the first recommended nutritional interventions.
Right. Right.
And recommended dose is 1 to 1.9 gram, on average 1.2 gram. And there are a lot of studies saying that calcium supplementation can at least reduce the incidence of preeclampsia.
Right. Right. Thank you, Dr. Purva, for those inputs. So calcium, yes, in the right dose, if the mother is deficient, requires calcium to prevent preeclampsia, but nothing else helps. Bed rest does not help. Vitamin C does not help. Nothing else helps. I have a question for Dr. Aparna. There's lots happening as far as pravastatin is concerned to prevent preeclampsia. A lot of studies. Are we ready to take it forward in clinical practice? Dr. Aparna.
You have to unmute yourself, Apurna.
Dr. Aparna, please unmute yourself.
Please
Dr.
allow.
Yes, there we are. Yeah.
Okay, please allow me to unmute. I think I'm not the co-host, so I think that's
Now
the
we can
problem.
hear you clearly.
Okay, thank you very much. A very good evening to all of you. And I think SFM is doing a very great job on the preeclampsia day. It's very important. And Dr. Khurana, what a marathon talk on preeclampsia. Like really, a great filler on preeclampsia. Really great words of wisdom. So yes, I think pravastatin, I have been trying for 1 year to start a trial on pravastatin because it's high time that we talk about pravastatin, because now there has been like a lot of study. See, we have situations where there is aspirin resistance. The problem with aspirin is that there is a small window where we can start aspirin, that is between less than 16 weeks. There are people who are resistant to aspirin. Also, there are situations in which the dose of aspirin is not adequate. So there is a huge window and also opportunity to start pravastatin. So, but the only problem is that it has not yet received FDA approval for use. So it has only been used in so there have been animal studies. There have been studies which have proven that it is better than aspirin. And so definitely it is time. But yet, I think the clinical trials have to happen in India. Most importantly, let me tell you, it's not available in India. So if I want to do a trial, so in fact, when I tried to get pravastatin to do the trial, I had to take a company on board that they promised me that they will manufacture it for me. So even if we discuss this theoretically, yes, it is time that we think of pravastatin, but there is still time when we can actually get it on floor. But sometime this year, maybe we'll be able to do this.
Right. Thank you, Dr. Aparna. So we do have meta-analysis coming up, which say that it definitely makes a
So
difference.
now if you talk about prevention of preeclampsia and prevention of uteroplacental related problems, when you talk about the newer drugs, so there are something called as repurposed drugs and the newer drugs on the block. So there's a very good article in the NEJM also. So in addition to aspirin, you have HCQ. In addition to that, you have pravastatin, you have metformin, and you have esomeprazole. So these are the new drugs on the block that we have to think about when we are trying to prevent and treat preeclampsia. So I think all of these drugs, I think we'll be talking about a lot in this coming year and the next. So a lot of them, but pravastatin is not going to come in very soon.
Right. Thank you, Dr. Aparna, for those inputs. So we're still not ready as far as using it in clinical practice is concerned, but it maybe in future it will be there. So I come to my next case. This woman, she developed preeclampsia in 2017. 2021, she again, she was started on aspirin because of a previous history. She was high risk, and she still developed preeclampsia at 29 weeks, 6 days, and underwent a cesarean section. In 2023, she comes with a pregnancy. And if you look at her risk, epidemiological factor, her biometry, and even if PLGF was not added, her risk was 1 in 3. Now, my question to Dr. Charmila is she a candidate for low molecular weight heparin with aspirin?
I don't think heparin will help a patient to prevent preeclampsia. So it's probably her maternal characteristics should be corrected before she become pregnant, and giving her aspirin and calcium will help her. I don't think heparin can be used when you don't have an indication. It can cause problems also.
Right. But we have some...
But Dr. Reema, what is her APLA profile?
Her APLA profile was negative. That was done. Thrombophilia
Usually they are like that, seronegative.
So I think, Dr. Reema, in here, we have to think about the form of APLA. I think we must think about it.
Yeah.
So is it like a seronegative APLA, right?
Yeah,
Is it obstetric APLA or is it non-criteria APLA? We have to think about other forms, and definitely there may be some merit, I feel, that in giving low heparin because she's actually and also, yes.
No, how do you diagnose seronegative APLA?
So, madam, there are certain criteria in which, I mean, the discussion might go towards APLA, but definitely, but there is a spectrum of APLA that we talk about here, and one is seronegative, one is non-criteria APLA. And in those situations where there is clinical criteria meeting, but lab criteria not meeting, in those situation, it has been seen that there could be some benefit, and there are systematic reviews and studies which have shown, and this is a very typical condition where there is evidence of uteroplacental insufficiency leading to a preterm delivery before 34 weeks. That's a very strong criteria, and if you have a placental histopathological evidence proving that would even more substantiate your need to do that. But yes, I mean, definitely not 100% evidence, but there is a strong evidence in this case.
Yes. So in view of a previous preeclampsia, and we're thinking in terms of obstetric APLA, which is seronegative, and it's just found that low molecular weight heparin, the recent meta-analysis that's come up in 2024, that if you give LMWH with aspirin, it definitely may improve the outcome. Of course, with LMWH, aspirin needs to be added. So we did give her LMWH and aspirin from 12 weeks. She did, in spite of this, develop preeclampsia at 35 weeks. However, there was no FGR, and we delivered at 37 weeks by cesarean section. So the take home is that there could be certain select indications for LMWH, but every patient is not to be started on LMWH. Now, coming to my next question for Dr. Khurana is, sir, this was this 35-year-old primary gravida. She had PCOS, oligomenorrhea. She missed her first trimester screening. She directly came for a level 2 scan. Now, will you want to screen in the second trimester for preeclampsia, and how would you do that?
Not an unusual situation, actually, Reema, because a lot of patients do miss and they land up only in the so-called 5th month. And we should be very much aware of this. We do understand that we presume that we have just an a priori risk, which would depend on her clinical features. And when she comes in at the time of the anomaly scan, we like to do it as close to 22 weeks, because that will also give us a much better idea of trophoblastic invasion of the spiral arteries. And then we reclassify her based on our findings at that time. And at that time, we would go by the uterine artery Doppler. And I would, of course, push and push and push. And that's how we managed to get SFLT PLGF into Delhi, that I would add that to my calculation so that I have a better calculation on whether she moves into a high risk with increased surveillance, or she just goes home happily and comes back at the time of a 30-week scan.
Right, sir. Thank you so much, sir. So it's just uterine artery may not be the best tool, but adding SFLT PLGF, as you mentioned, could help us to screen better. And sir, would you start aspirin for her? That's my question. Now she comes with increased uterine artery resistance in the second trimester. She's high risk for preeclampsia and she's at 22 weeks. Would you want aspirin?
So not that I'm an obstetrician, but I can give you world opinion from what I hear all year round every weekend. The important consideration here is prevention of preeclampsia using aspirin versus improving pregnancy outcomes using low-dose aspirin. Now, when we look at the prevention of preeclampsia and the late onset of administering aspirin, it has absolutely no role in preventing preeclampsia. It will not prevent the preeclampsia, and that is very clearly evidenced also from aspirin. On the other side, we do understand that the process of atherosis, which is vasoconstriction and atherosclerosis going on at the same time in the placenta, can be decelerated to a point where the onset of severe atherosclerosis within the placenta and therefore placental ischemia will get postponed by almost 6 weeks. So in that situation, low-dose aspirin will possibly prevent complications. We do need robust evidence, but there is no doubt that randomly it seems to improve outcomes in terms of growth restriction, in terms of stillbirths, in terms of having to deliver preterm.
Right. So thank you so much. So it's very clear that till 16 weeks, 6 days, even if the patient has missed the first trimester screening and we have some risk factors, abnormal uterine, definitely are an indication to start aspirin. Beyond that, as sir mentioned, we have to take it as case-to-case basis and take a call on whether to start aspirin for our patient or not. Now, my question to Dr. Charmila is, now this patient comes to you, should aspirin be stopped if the second trimester, she had high risk on first trimester and she comes to you and the second trimester Dopplers, uterines are less than the 95th centile. So this is a common practical situation and patient will ask, now my uterines are normal, doctor. You think I should continue with aspirin or should I stop it?
Yeah.
So how would you
Yeah, traditionally, we give aspirin and stop it around 36 weeks of pregnancy. But I think there was a recent study in JAMA where they said stopping aspirin at an earlier gestational age of like 24 to 28 weeks is non-inferior to continuing aspirin till 36 weeks. So probably we'll have to change our practice in a group of patients and tell them like if it's fine, they can actually stop and it will not cause much of a problem based on this study. But still, we are giving aspirin till 36 weeks of pregnancy in our practice.
Right. So, Dr. Aparna, would you change your practice by stopping aspirin? Though the
I
trial
tried doing that in 2 times and they got so anxious. They were like, okay, I've stopped. Do you think it's going to happen? Or I don't know. I mean, it's going to take more evidence, to look at that. And I don't think one or two studies. I think there's more evidence, and I think probably we should also generate some evidence around it. But yes, it makes sense, to talk about it because, once the wave of trophoblastic invasion has occurred and there is some amount of the uterine artery Doppler is fine at this point and the vascularity is all right. So it makes some sense to say that you can possibly stop aspirin, but we still have to look at the evidence. I would not drastically change my practice at this point, but I will say that I did try it in a few patients. They freaked out so much that I said, okay, fine, don't do anything, continue.
So I think
I would not jump to any
so
conclusions.
we need to build up more evidence. Yes, definitely. So I come to my next case. This is this 30 weeks woman who comes with persistent headache. Her blood pressures are high in the range of 146/94. Hematological and biochemical markers are normal. She's FGR stage 1. Now, how would you take the angiogenic factors forward, Dr. Aparna?
Yeah, so I think angiogenic factors have really changed the way we look at preeclampsia now. And we included that in the routine practice. Now, say for example, case, just if you could go back to the previous slide, Dr. Rima.
Yeah.
Yes. So now see, this lady is 30 weeks and her blood pressure is 84, which is not very high for me. But this persistent headache, now that will make me suspect if this is like, say, impending eclampsia. Now her urine albumin may be 1+ or 2+, but it's not very definitive. So I'm not sure whether I'm sitting on something which is preeclamptic or not. I should be admitting her. I should be sending her home. Is she something? Is there something brewing which I'm not sure? So what I will do is I will send a simple SFLT PLGF ratio. And for me, the report might come in a day, but most of the labs will take 2 days maybe. And the report comes. Now, there are 3 cutoffs, right? So if for me, the report says that SFLT PLGF ratio is, say, is less than 38. So I am happy that the PLGF, which is the denominator, is high and it is a good factor. So PLGF is high. I'm not worried. It is not preeclampsia. So it rules out preeclampsia. So I'm happy and I'll say it is not preeclampsia. You're just gestational hypertension. Take a crocin for your headache and go home. But I'll keep a watch on you. So this is a good thing. But if it tells me, and you are a preterm, if it tells me that your SFLT PLGF ratio is more than 110, it tells me that you are preeclampsia. But then, because it is only 110, it may not be severe preeclampsia. We are sitting on preeclampsia. Let us now reevaluate more. But if it tells me that your ratios are in the range of 500 or 600, then it may be impending eclampsia. I will be more careful. So this is how I stratify my patients and I tell them and I manage them. And then I do my inpatient versus outpatient management. And I am at rest and at peace and my team is at peace and the patient is at peace. So SFLT PLGF ratio really tells us a very, very tailored approach to managing these patients.
Right.
And of course, we have the evidence to say that they work.
Yeah, right. Dr. Panna, and I think this is a wonderful tool and the cost should come down, which Khurana sir will definitely ensure that the cost comes down. So we get it into.
Yes, sir. It is prohibitive right now. It is costing us 3,500 rupees if we are sending it outside. At AIMS, we are probably, thanks to our lab medicine teams, I think we are doing it at a cost of around 1,200 to 1,500 rupees. But I think it is prohibitive.
So we need to get the cost down. It's a wonderful tool which we can use into, finding out whether this woman is likely to get preeclamptic with a negative predictive value of almost 99%.
Yeah. And if we use it to the full potential, there is nothing like it. I think there is no test like it.
And I just read this article which came out in our own Journal of Fetal Medicine by the AIMS team, and they have used SFLT PLGF ratio in hypertensive women, and they found that it does change your clinical practice. And of course, it's not just the ratio, it's also the PLGF alone, which can be utilized, which can get the cost factor down, and it performs at 96% sensitivity. So this longitudinally increasing the role of longitudinal values of PLGF may have a role if we can't use the PLGF SFLT ratio. So my question is that in twins, can we use it, Dr. Panna? Twins is something where preeclampsia comes up, we are worried. So
no.
are we?
Currently, there is limited role of SFLT, PLJ, but I'm sure there will be some more values which we have to figure out. The cutoffs are not yet clear in twins and not requisite trials are there, but I'm sure things are going to work out. Dr. Manisha is doing an ICMR project on SFLT, PLGF on twins. So I'm sure something is going to come out, but there are a lot of trials which are going on. So maybe sometime next year, we'll have a lot of more information on it.
It looks very promising, right? Yeah. So this patient of ours had a SFLT PLGF of 2,321.
Severe preeclampsia.
Severe preeclampsia. The risk of complication within a week was 90%. So she just came with headache and a blood pressure of 146/92, where you would not have suspected severe preeclampsia, but the SFLT PLGF ratio showed us the way, and she was admitted and terminated at 32 weeks. So it's some tool that we really can use in our clinical practice. Dr. Khurana, ophthalmic artery has come up a big way, and we're all talking about it in the first trimester, second trimester, third trimester. So you have to tell us that, is it a complementary tool or can we incorporate it into our clinical practice?
So it's currently under investigation, but there is no doubt that when we use it as a single tool at 36 weeks of gestation in our term scan, we can get exactly the same amount of information as we would get if we were to do the whole algorithm, which means clinical characteristics plus maternal ophthalmic artery Doppler, and you don't need your uterine artery Doppler and you don't need your biochemistry, as you've shown in this paper from the Nicolaides group. Then there is exactly something similar that you and me have at the 22-week screening window, where we have again found that we can perhaps skip our SFLT ratio and PLGF if we include our maternal ophthalmic artery Doppler. Now, maternal ophthalmic artery Doppler, fortunately for us, is a relatively inexpensive test because the ultrasound scanner is used for so many things as well. Not completely inexpensive because most obstetric units will not have a superficial parts transducer. So we will have to do that little bit of an investment more. And of course, the skills are not very much. If you're used to ultrasound scans, it's something that requires no preparation. You just shut the eyes, don't remove the makeup, put the transducer there, and you pick up only one vessel, and you get the two systolic peaks, and you divide them, and you get your answer. You do 2 on the right side, 2 on the left side, and as long as you've done those, you have close to 100% prediction for what is going wrong. So at 22 weeks and at 36 weeks, it is well established. What is currently under investigation with the Fetal Medicine Foundation is its utility and whether we can dispense with PLGF and uterine artery Doppler when we do maternal ophthalmic artery Doppler at 12 to 14 weeks of gestation. That is currently under investigation, and we hope in the next 2 years we will have numbers on that as well.
Thank you, sir. So this is also going to become one of the powerful tools in the coming future.
Absolutely true.
And this urinary Congo red preeclampsia detection point of care test, which the study again has been done by Khurana sir and Dr. Aparna. And we would want insights into how we can again translate into clinical practice. And this would be more useful for Dr. Charmila in the rural area where you have a point of care test for preeclampsia. So I would request sir and Dr. Aparna to tell us where we are with it.
Well, I'll fit you into the background. The background was that one of the companies came up with this test. The units were manufactured in China, and it seemed to work well in our background of non-booked patients. Patient walks in. I've never seen her before. She's either going to die or the baby's going to die. What do I do? I needed an answer. And so we thought this was an ideal product. I'll leave the floor now to Dr. Parna Sharma to tell us how she went through all of this and what happened.
Thank you, sir. It was all the entire coordination was thanks to sir. So what we really did was in this particular things, we had 4 centers from Delhi, all the medical colleges of Delhi. 600 women were enrolled in the study. And this urinary Congo red is actually it's like pregnancy kit. And what we are trying to detect is the misfolding proteins, the amyloid proteins in the urine, which actually appear 1-2 weeks before preeclampsia. So in this particular group of women, out of the 600 women, they were in women who were at high risk of preeclampsia, like gestational hypertension, in suspected preeclampsia. And it was seen that the possibility, so the positive predictive value of the test was around 55%. However, the negative predictive value was 85%. So although the rule-in was low, the rule-out was 98%. So if the test was negative, so the chances that the woman would have preeclampsia in the next 7 days was very low. So that means you can rule out preeclampsia. So again, suspected preeclampsia, test negative, she will not have preeclampsia, much like the SFLT-PLGF ratio. So that is the advantage. And it is now again, so in between the marketing was stopped for some reason, but now again the kit has available, and it just few days before the company came again, and I think it's now again commercially available. So it's a very useful test to be available by a bedside as a clinical test, and it's a useful device, so we all can use it possibly shortly.
So it's a
And
very,
it's a urinary test, so it's very easy to do in the OPD.
especially rural
Not even
population,
a blood test.
benefits, yes. So I come to my next case, this 39-year-old woman at 31 weeks, 4 days. She has persistent headache, epigastric pain. She has not undergone first trimester preeclampsia screening, so she's not on aspirin. Her blood pressure was 160, 110 when she came. Edema was increasing. Her platelets were 1 lakh. The ALT, AST was rising. The PC ratio was increased, and the fetus had FGR stage 1. So we had all the features of so I would want Dr. Charmila to take that. What would you suggest as your diagnosis at this point of time?
It's a early preterm preeclampsia, and very like characteristic in the way that she's having all the organ damages, and this is a patient who needs to be delivered, and probably you can't even wait for steroids because I think she's developing HELP also. Platelets are dropping, and all the enzymes are getting elevated. Already she's having a symptom. So I think the management should be delivery. So any patient who needs delivery before 34 weeks comes under the category of early preeclampsia, and it's more of a placental disorder where the fetus is also affected. So this baby is also having growth restriction stage 1. So all is characteristic of a mother who is having it usually happens in multis. That's what we're seeing. Late preeclampsia seem to be more common in primi, but we're having a population where you have early, it's usually multis, or they would have a history of preeclampsia in the previous pregnancy. So those mothers have to be actually screened and taken up correctly in the early trimesters itself. So for this patient, for us, it will be delivery, and that will be after resuscitating the mother, and that will controlling her hypertension, giving her magnesium sulfate for herself as well as the baby, and then you take up the mother for delivery. And if her lab parameters are not trending to a higher level, probably you can wait for the lung maturation and then deliver. But if the enzymes are going to become higher and the platelets are going to drop, it's better that you deliver early before it becomes worse.
Right. So she would require admission, IV labetalol, magnesium sulfate, and fetal lung maturation. So we really need strict monitoring. Fluids need to be curtailed. Diuresis needs to be monitored. She may be a candidate for low molecular weight heparin, and magnesium sulfate is definitely both for neuroprotection and for the mother. So
IV fluids is the most important part. Paramedical people tend to push IV fluids into mothers when they are admitted, and that should be totally banned because the mother usually lands up with pulmonary edema when you give that fluid at a very fast rate.
All that needs to be really managed well. The fluids, the blood pressures, the seizure prophylaxis, everything has to be done well. As far as drugs are concerned, what would be your first line of choice of drug for acute control of blood pressure?
We use IV labetalol, and it gives a much better control because oral nifedipine, many times it takes a little longer time to act, and that's why we prefer IV labetalol here.
Dr. Brigadier Navreet is here with us, a cardiologist. Do you think differently? So a lot of times we send you patients where we're not able to control blood pressure and we call for you. So how would you, so if labetalol does not work, what is your next choice?
I think hydralazine is a very good choice, a second good choice. It does have its benefits being basically a direct vasodilator. But I think before, just on the sidelines of this, we should, if possible, do an echo because an echocardiogram does, especially if the patients are sick, an echocardiogram would be on the cards because I would like to see the left ventricular function and the pulmonary artery pressures. It would help me, think of whether diuresis has to be given a more important role or just vasodilatation, because we must remember it's more of a systemic disease rather than and cardiac manifestations are more of the systemic illness. So an echocardiogram to check the LV functions. Most preeclamptics would have a near normal LV function, but they do have stiffer ventricles. While it is difficult clinically sometimes to differentiate from pericardium cardiomyopathy because these patients are slightly edematous, they have pedal edema. So an echo should be done. I think that's probably the first thing which I would, before going on to higher level of drugs. Of course, nitroprusside is not to be used, but I would think of using some amount of nitroglycerin sometimes to reduce the pressures because it also decreases the preload. And a little bit of the edema which happens in the lungs is not only cardiogenic, but also just because of vasoreactivity.
Thank you so much, sir.
If I may just interrupt once at this time, I want to know the opinion of Chinmay Umarji, who works very strictly with protocols in his organization. And this topic came up just a few minutes ago on how we have to make sure that our paramedics don't push medication, don't overload our patient with fluids and so on. So if you don't mind, Rima, may I ask his opinion on how he's managing at a practical level to push these protocols and what to do in chronic, acute versus subacute or severe situations?
Thank you, sir, for your kind question. And I couldn't agree more with yourself and Charmila ma'am that we need to handhold our paramedics. And the best way forward, of course, is training, retraining, auditing, and training again. So conducting courses like also advanced life support in obstetrics, and keeping in our mind that we don't have luxury like the eminent cardiologist here to have an ICU with us. So, like say for hydralazine, it happens so that there could be severe hypotension, and I know that my midwife is not likely to pick it up and manage it as good as a ICU nurse. So, optimizing our protocols based on evidence always helps, and making the road your highway. For example, the question concerned here was, are paramedics going to push fluid? And if you just put a machine in between, make sure that you clearly instruct them that your fluid intake should be 80 ml per hour, of which you are going to give your IV magnesium sulfate at say 4 gram per hour or 2 to 3 grams per hour. From there, using syringe pumps and using devices, which again, we have to come out of this mentality that we are still somehow a developing nation and we cannot afford a syringe pump or an infusion pump for our patients, and using them like ICU nurses do so that we can safeguard our patients and ourselves well. So I think that answers our question, sir.
Thank you, Dr. Chinmay.
Thank you.
Really nice, because practically what we need to do is very, very important. So this patient did have oliguria, urine output decreased, there was worsening blood test, platelet came down, the liver enzymes increased. So of course, magnesium sulfate was maintained, dexamethasone was started, diuresis decreased. Now, does she fit into the criteria for delivery at this moment? Dr. Chinmay, you could take that on. Would you want to deliver this woman now?
Absolutely, ma'am, because she's in severe preeclampsia. We have made sure that her heart is okay. We have tried to control her blood pressure, and now it is necessary to safeguard herself and her baby. And the only way out is delivery. So we need to get this baby out, and we need to get this mother.
Thank
cured.
you. So, absolutely right. Refractive blood pressure, not responding to medication, prodromal symptoms, organ damage, all of this becomes an indication to deliver. Now, Dr. Aparna, we have some predictors for maternal mortality, other than the biomarkers you spoke about, something that we can use where we don't have biomarkers. So could you just let us know a little about it? You have to unmute yourself.
Sorry. Yes. So, in clinical practice, we use some other biomarker predictors, like what we is most commonly used is the full Pire score, which is a combination of the saturation, and then we use the ALT in that, we use the platelet count, and we use if there is any history of dyspnea. Now, there are other things, like there is something called a PrEP S and a PrEP L scores, but clinically speaking, it has not been like validated too much for inter-country, inter-ethnicity or inter-population validation has not been done too much. And in fact, when I was reviewing the literature, there is a 2024 article which has systematically looked at all of the adverse outcome predictors. And the only thing that has really held up is the full Pire score as a validated tool. And yes, and if it is showing, so the full Pire score is actually a combination of various features that you have told previously. So that shows the gestational age, the SpO2, the platelet count, and ALT, the creatinine, and then in the end, it will calculate and tell you what is the risk to the mother. So if between 30 to 34 weeks, so if you have a significant risk to the mother, then you would think of possibly delivery. But somehow clinical practice has not really caught on to these predictors, and we have really been got on, see, typically if, there are signs and symptoms of impending eclampsia, there are signs and symptoms of HELP syndrome, or if there is a fetal compromise, then those are the situations that we would go for delivery. Suggestive of severe preeclampsia. So we know a cutoff of more than 34 weeks, severe preeclampsia, we would deliver. Between 32 to 34 weeks, anything which is compromising the condition of the mother or the fetus, we would like to deliver. So I think these are the more of the clinical features, or we depend more on clinical signs and symptoms. Despite my 100, I would say, admonitions, we have not really caught on to full PIRE scores as much. And there is some method to it, this also. And this has shown, the recent systematic review also has shown that they have not like truly very useful, I suppose. But yes, there are indicators, I would say.
So we have, suppose you're in the rural setting and you can, use this maybe, but not in the tertiary hospital. But yes, SFLT-PLGF ratio is here to stay, which will help us with pregnancy termination.
I would again depend on the SFLT-PLGF ratio. It does give, if it is very much increased and you are beyond 34 weeks, so you would again consider it a severe preeclampsia, and you would more inclined to deliver rather than waiting. So I think that's again a very, very useful tool. And remember, the cutoffs are 110 for a late preeclampsia and 85 for an early preeclampsia. So that is something.
Thank you. So this patient did undergo cesarean section, magnesium sulfate postpartum, corticosteroids, 48 postpartum, blood transfusion, labetalol, discharge 6 days post-cesarean. So she was delivered and did have a good outcome. Now, I would just quickly go through this case. We have to finish our panel on time. So we have this 32-year-old Dr. Chinmay who comes to us at 36 weeks. BP is fluctuating between 143-89, BMI is 28, there's no history of hypertension, her urine proteins are okay, her hematological biochemical tests are all fine. Now, would you want to follow her up because she's at 36 weeks, 3 days, or would you just tell her, okay, come back after 2 weeks?
So she has mild gestational hypertension. And we know that there is a significant chance of this mild to progress to either severe or preeclampsia. So she's somebody who needs extra vigilance. And sometimes in our busy clinical practice, we may underestimate that. And probably that is the reason why we have the highest number of eclampsias in the world. So that is something which we need to very proactively work upon.
Right. So even mild preeclampsia, late preeclampsia needs to be monitored, rest, diet, BP monitoring, and weekly follow-up. So this patient, within a week, her protein to creatinine ratio increased, and she had a diagnosis of late-onset mild preeclampsia. So, Dr. Aparna, I just want to ask you, because you're doing so many biomarkers, at this point, would you want to do biomarker for her at 37 weeks, 2 days, with a PC ratio that's getting altered? Or would you want to deliver her, or would you want to do some biomarkers? It's a very practical thing.
I'm very zealous about my biomarkers, but I am not impractical. I will deliver her.
So we would deliver her, that's for sure. So Dr. Chinmay, I want to ask you that we had this study that gave us a lot of information, induction versus waiting for expectant management. So definitely, I think all of us here would agree that we would want to deliver this patient at 37 weeks. Anybody thinks differently? No. But I have this, we have certain recommendations, I mean, not recommendations, but certain studies coming up that say that the delivery between 34 to 37 weeks could be considered and does not have a long-term impact on the baby, the neonatal outcome, and definitely improves the maternal outcome. So I want anybody who would want to take on this question. What is your take on this 34 to 37 weeks delivery?
But this is without severe features.
She's
Yeah, without
controlled.
severe features. Yes.
Yeah, so if it is P, mostly you deliver by 37, right? With severe features, 34, P, without severe, 37. Whatever we are not going beyond 37 plus 6 anyway. I mean, so P is 37.
Yes.
There is no
Yeah, but people are talking now, the certain studies which are comparing, they do talk about delivery at even 34, between 34 to 37. But as far as we are concerned, I think
Yes,
37.
we are trying to push it. Like, so it is not
Ah.
beyond 37, between 34 to 37, if that is a plus minus that we are trying to push. So it is expected. So if you look at these studies, the maximum gain that has been achieved in terms of number of days is between 5 to 7 days. And that is for the benefit of the baby. So what, in terms of the mild preeclampsia without severe features, why will we deliver before 37? So this is the question. And yes, of course, expectant management. So even this particular gestational age between 34 to 37 is because you want to push it till 37. And of course, if there are features that are like, say, a fetal distress or, any compromise, you will anyway deliver before that. But we try to push it. The maximum limit is 37. There is no question after 37 anyway.
Preeclampsia with no severe features is 37, but yes, we increase our vigilance on these mothers. So this woman delivered, had labor induction, but emergency cesarean. Baby we did well after delivery. So so we've had this entire gamut of screening and management and delivery options, but there's a lot of paradigm change that's happening. We are moving from the placenta to the heart, and we are saying that no, it's the placenta that's not the villain, it's the mother's heart that's the villain, because that's responsible for the placenta not doing well. So here I would want Brigadier Navreet to tell us that how is this pregnant heart different? It performs like an Olympic heart. So it's working immensely. It's working 24 hours, 7 days, 9 months. So is it any different? So you have to unmute yourself.
Okay. So there is no doubt that the heart is at stress both by the volume of blood that it has to pump as well as the force. So those changes are physiological. I mean, a pregnancy is a physiological phenomenon. So the heart does normally do it very physiologically well. But in the case where endothelial dysfunction comes in, where all these gamut of cytokines start bombarding the system, that's when the heart tends to hello?
So we can hear you. We can hear
Okay.
you.
Okay. I'm so sorry, there was a phone call. So that's when the heart gets bombarded, and that's when these changes begin to happen. The heart muscle, by way, has got a great resilience. So it can take a lot of beating. So the first thing it does is it starts to become thicker. It becomes thicker and stiffer. And that's what's so characteristic of preeclampsia, eclampsia, where the heart tends to become more stiff, and therefore its ability to receive blood from the left atrium and also from the pulmonary circulation, ऊपर से खून आता ही नहीं है. It can't expand to collect that blood and pump it further. So that's what we call it as diastolic dysfunction, and those are the parameters which we generally find way out in ladies who are even bordering preeclampsia, even certainly before preeclampsia, that they start to become their indices of diastolic dysfunction go bad. But as I always said, that when a lady is referred to us, most of the time, though she may be borderline hypertensive, we are worried that it's not peripartum cardiomyopathy, because it's in the same time frame that they do present, and that's why systolic dysfunction is something which also can appear. And if you have just a slight systolic dysfunction, and major diastolic dysfunction is when you get worried, you really don't know which way the mother is going to swing, whether she's going, and they're more prone to have peripartum cardiomyopathy. So you don't know which way they're going to swing. But I think the load on the heart is predominantly because of the endothelial dysfunction. And as everyone said, ecosprin is good. I would think to believe that if you start to have some amount of heart failure, heparin should be given, whether it's in the guidelines as a class 1 indication or not, but more so that they also tend to develop pulmonary arterial hypertension and some sort of pulmonary infarcts. So therefore, I think in that setting, low molecular heparin should also be thought of. As far as the heart goes, the recovery is very good in preeclamptics, though there may be some residual, microscopic evidence of fibrosis, but by and large, they do pretty well the systolic function because the main endothelial dysfunction goes away.
Right. Thank you, sir. But just a little, Sir Khurana sir touched upon in the beginning that there is some postpartum residue that stays. So preeclampsia does not finish with pregnancy, but the heart.
Yes, yes.
So could you just tell us in brief about what is this all about?
You mean following pregnancy?
Following pregnancy, the heart does not revert to the preeclampsia does not revert. So it's a long drawn process, right?
Yes. So as I said, the effects of endothelial dysfunction, that's predominantly the inflammation that causes the changes right from the myocardial, the muscles itself are hit, and that's what causes, as I said, the diastolic dysfunction. That's the stiffening is what really persists after pregnancy, and it may not manifest immediately. It may not manifest immediately as clinically manifested, but they certainly can have a much later presence of diastolic heart failure. Now, whether we start them on medications for diastolic dysfunction in pregnancy as well as early part of the postpartum period is always a debate, because the drugs which we give, empagliflozin, dapagliflozin, they are really not being tested scientifically. But yes, if they persist to have some amount of diastolic dysfunction down the road, we would probably, but yes, sir, absolutely right that diastolic dysfunction does persist much longer, and a significant number may carry on. Also because quite a few of them are obese, they're diabetics, and so you just don't know where the risk factors are pushing in, and where just the preeclamptic or the toxicity has hit the heart.
Right. Thank you so much, sir. So we really don't know what believe that it's heart that's the culprit or it's the preeclampsia. But yes, a lot of studies are happening and we really don't know whom to blame. It's the heart or it's the placenta. There's a lot of work that's happening and we will come up with more answers in future. So I would end this panel by saying that our take-home message is just one, and that is vigilance, and that vigilance is across the trimesters, is the first, the second, and the third trimester. And that's what the Society of Fetal Medicine also believes in, that we need to increase awareness and be vigilant on this dreaded condition that is preeclampsia. Thank you to my wonderful panelists for such crisp inputs and for making us finish this panel on time. Now, with this wonderful inputs, we have icing on the cake by lecture none other than Dr. Kamal Gujral, who will take us through the preeclampsia, what we need to know about the definitions and how do we diagnose it.
And then we'll take the questions at the end of that talk. Yes.
I would request Dr. Kamal to kindly.
Rima, I would need to leave now because I'm in a resort here. The dinner is closing now.
Sure.
So I need to go.
I'm
I'm in Sri Lanka, sir. That's why that the problem is there. But thank you so much. Thank you.
May I also have the permission, ma'am, with the esteemed panel? Thank you so much. It's so wonderful to be among such varied esteemed faculty. I of course have gone. I forgot to mention that measuring your own blood pressure is what has to be taught to these to every pregnant lady. That अपना BP खुद घर पे check कीजिएगा. 1000 रुपए की machine है. It's worth it. It's worth it. It saves so much time, money, effort, and they can be caught much earlier. So with that, I take permission.
So over to Dr. Kamal Gujral for her talk.
Yeah, my sincere apologies. I don't know what went wrong. I was making slides in patches. Those patches came first, and I didn't check the final one. Anyway, I'm so sorry. Apologies again. So we go on quickly. As I said earlier, 4 guidelines we refer to: ACOG, International Society for the Study of Hypertension in Pregnancy 2021, NICE 2010, 1923, and the nomenclature of 2010 is carried on in the further two guidelines, and FOGC, hypertensive disorders of pregnancy. So let's look at the hypertension occurring at 20 weeks and beyond. We already said this: gestational hypertension, new onset hypertension, 140 systolic and above, diastolic 90 and above, two occasions 4 hours apart after 20 weeks of gestation in a previously normotensive woman. And there is no proteinuria, there is no sign and symptom of preeclampsia related end organ dysfunction like thrombocytopenia, acute kidney injury, elevated liver enzymes, pulmonary edema, cerebral or visual disturbances. Now, preeclampsia is a new onset systolic blood pressure of 140 and above, diastolic 90 or above, two occasions 4 hours apart after 20 weeks of pregnancy in a previously normotensive woman. If the BP is 160 and above and diastolic 110 and above, you do not wait for 4 hours. You are going to repeat BP in 15 minutes so that you can start an antihypertensive therapy. And preeclampsia, besides the hypertension, would have proteinuria, 300 milligram in 24 hours collection, or a protein creatinine ratio of 0.3 or above, or urine dipstick 2+ if the other two are not available. In a patient, in the absence of proteinuria, you can still diagnose it as preeclampsia if any signs, features of severe disease are present, we just now mentioned in the previous slide. So it is proteinuria in the absence of that, other signs, symptoms of preeclampsia. Now, this is where we left. That severe features, earlier it was mild, moderate, severe, given off. Severe preeclampsia term given off. It's now preeclampsia with severe features or without severe features by ACOG. So any one of the following factors: systolic BP of 160 millimeter and above, diastolic 110 or above, two occasions 4 hours apart, unless you've started an antihypertensive therapy. Platelet count of 100,000, less than that. Impaired liver function as indicated by liver SGOT beta AST/LT, twice the normal concentration. Severe persistent right upper quadrant or epigastric pain, unresponsive to medication, not accepted by altered diagnosis or both. Acute kidney injury, creatinine of 1.1 or above, or doubling of serum creatinine in the absence of kidney disease, pulmonary edema, cerebral or visual disturbances. Any one or more of these features makes it as preeclampsia with severe features. Eclampsia, chronic or clonic convulsions in the absence of other diagnosis, woman who's hypertensive. HELP syndrome, no ambiguity, hemolysis, elevated liver enzymes, low platelets, hypertension may be present. HELP in such cases considered as a variant of preeclampsia syndrome if we do not get hypertension. Now, superimposed preeclampsia, chronic hypertension with superimposed preeclampsia, any of these findings in a patient who has a chronic hypertension, sudden increase in the blood pressure that was previously well controlled, or an escalation of antihypertensive therapy required to control the blood pressure, new onset proteinuria, or a sudden increase in proteinuria in a patient with a known proteinuria in early pregnancy. Significant new end organ dysfunction consistent with preeclampsia after 20 weeks of gestation or postpartum. We just defined those features. That's a superimposed preeclampsia on chronic hypertension. Now, this is practically the same, but I do not know why we divide it differently. Chronic hypertension with superimposed preeclampsia with severe features we have just outlined. They are defined to mild. This is called as chronic hypertension with superimposed preeclampsia with severe feature. That was without severe features. That was ACOG. Now, coming to International Society for the Study of Hypertensive Disorder Pregnancy, gestational hypertension, hypertension de novo at 20 weeks or after, in the absence of proteinuria or other findings suggestive of preeclampsia, practically same. Transient gestational hypertension, this is a new term coined by the society. Hypertension rising at 20 weeks and beyond in the clinic, which resolves on further BP readings. That's called as transient gestational hypertension. Preeclampsia de novo. This is a gestational hypertension by any one or more of the following: proteinuria, other maternal end organ dysfunction, neurological complications, pulmonary edema, hematological complication rate test less than 1.5. Americans had it 1 lakh. Acute kidney injury, 1 milligram or more. Raised transaminases and, AST, ALT more than 40, with or without upper quadrant pain. Now, the difference between the Americans and this is this, that ACOG had removed proteinuria, as I said earlier, in 2013, because they felt proteinuria is never an indication for delivery, and we just not discussed that in the panel as well. And growth restriction also, they removed it, which was there prior to 2013, because they felt that growth disorder is an entity in itself. It may or may not be without preeclampsia. So it's not a feature of preeclampsia with severe features. However, International Society for the Hypertensive Disorders in Pregnancy adds uteroplacental dysfunction. That is, you could have placental abruption, angiogenic imbalance. We just now heard that how important is PLGF in diagnosis of preeclampsia. So if that is present, that is preeclampsia, and the values will suggest high features. Growth restriction, abnormal umbilical artery Doppler waveforms analysis, or an intrauterine death. That is the feature extra than the American College. Preeclampsia superimposed on chronic hypertension is practically same. Chronic hypertension, development of new onset proteinuria, maternal organ dysfunction, or evidence of uteroplacental dysfunction again. Eclampsia definition is constant by all societies. Now, NICE, this was given in 2010. And as I said, they revised the 2 more revisions came, but definitions remain the same. Gestational hypertension is a new hypertension after 20 weeks of pregnancy without significant proteinuria. Preeclampsia, new hypertension after 20 weeks with proteinuria. They do not, say look at the other end organ dysfunction. Severe preeclampsia with severe hypertension with or without symptoms, biochemical or hematological impairment. Health remains the same. Eclampsia is a convulsive disorder associated with preeclampsia. Significant proteinuria is again 300 milligram 24 hours, 0.3 PC ratio, protein creatine ratio of 0.3 or 2 plus dipstick if other 2 tests are not available. Now, FOGSI defines general gestational hypertension 140, 90 and above, detected beyond 20 weeks of gestation, returns to normal within 40 days postpartum, and is not associated with any other features of preeclampsia, practically safe. Preeclampsia, they give an elaborate definition: multi-system inflammatory disorder beyond 20 weeks of pregnancy with significant proteinuria de novo, onset of hypertension and onset of hypertension. More recently, atypical variants of preeclampsia are recognized, which is accompanied by the neurological, hematological, hepatic renal dysfunction, which have been included in the definition of preeclampsia, and they call it as atypical preeclampsia, the FOGSI body. Further, FOGSI likes to divide this as non-severe preeclampsia, which is a blood pressure of 140 or 90 and above, but less than 160, 110, and no premonitory signs of symptoms of preeclampsia, and normal hypertensive disorder lab parameters. Severe preeclampsia 160, 110, with or without the hypertensive disorders lab parameters. And if the BP is 140, 90 and the lab parameters are abnormal, premonitory signs are present, then that is also severe preeclampsia. Now, they also like to divide it as early onset preeclampsia and late onset. Early onset starting before 34 weeks of pregnancy, because maternal complications are more severe. Low birth weight, growth restriction, iatrogenic prematurity are the main risks. Late onset after 34 weeks of pregnancy, maternal complications are less severe. Low birth weight, fetal growth restriction are less common because baby has attained its growth till 34 weeks. Superimposed preeclampsia, it is occurrence of preeclampsia in women with chronic hypertension. But once you diagnose preeclampsia, you must confirm the blood pressure in 4 to 6 hours, that it's a 2 rise, before we classify it as superimposed preeclampsia on chronic hypertension. Eclampsia is same, seizures with preeclampsia. It can also occur with atypical preeclampsia. Now, that was hypertension after 20 weeks of pregnancy. Now, hypertension occurring less than 20 weeks of pregnancy. ACOG Hypertension diagnosed or present before pregnancy on at least 2 occasions before 20 weeks. Hypertension that is first diagnosed during pregnancy and persists at least 12 weeks postpartum is also considered as a chronic hypertension. The criteria for BP are 140 and above systolic and 90 or above diastolic. Stage 1 hypertension at 12 weeks and are systolic 130 to 139, diastolic 80 to 90, stage 2, 140 systolic and above, and diastolic more than 90 or above. That is chronic hypertension by ACOG. Now, coming to International Society for the Study of Hypertension Disorders in Pregnancy, chronic hypertension is a hypertension detected pre-pregnancy or before 20 weeks gestation. It could be secondary hypertension with a known secondary cause, example, renal, autoimmune disease, etc. It could be without a known secondary cause. White coat hypertension is a term included in this society. Systolic blood pressure 140 and above, diastolic 90 or above, when measured in the office or clinic, but BP is less than 135, 85, using home BP monitoring or ambulatory BP monitoring. Masked hypertension, BP that is less than 140/90 at clinic or office, but more than 135/85 when measured at other times. Why these two terms are important? Because both these white coat and mask coat can later lead to gestational hypertension or preeclampsia. Patients have to be watched for. Now, NICE says chronic hypertension is hypertension present at the booking visit or before 20 weeks of pregnancy, or if the woman is already taking antihypertensive drugs when she attends the maternity service. It can be primary and secondary. From mild hypertension, diastolic 90 to 99, systolic hypertension 140 to 149, moderate hypertension, diastolic 100 to 109, systolic 150 to 159, severe hypertension, diastolic 110 above, and systolic 160 above, practically same. FOXY is the same definition, known case of hypertension or a case of hypertension detected before 20 weeks of gestation in the absence of neoplastic trophoblastic disease and multiple pregnancies. That's the only difference with the previous societies we have discussed. Now, since this whole thing revolves around measurement of blood pressure, it's better to know, it's essential to know that how to measure a blood pressure. The picture is shown. Woman has to be seated comfortably. Legs should be uncrossed. Back should be supported. Upper arm should be bare. Do not roll up the sleeves. Arm should be at the level of the heart. Cuff of the bladder should be 80% or more of the arm circumference. Mercury should be deflated at 2 to 3 millimeter per second. First and the last, that is a quarter of 5 sound, defines a systolic or diastolic BP. Neither the patient nor the doctor taking the blood pressure should talk. Why it is so? See, blood pressure is higher in supine position, and systolic blood pressure is higher in supine position, diastolic higher in sitting. So diastolic is the one we worried about. If you cross the legs, systolic blood pressure rises. If you do not rest the back, the diastolic blood pressure rises. Cuff of the bladder, if it's not covering 80% of the arm, there's an erroneous reading. Arm, if the arm is above the level of the heart, low readings are obtained. Arm below the level of heart, high readings are obtained. Unsupported arm, high readings are obtained. And if the mercury column is deflated at a speed more than 2 to 3 milliliter per second, systolic blood pressure is lower and diastolic blood pressure is higher. So all these minor variations can give us erroneous reading. So one must know these American Heart Association recommendations of how to take blood pressure. That's all I have to say about the guidelines. I once again apologize for all the mess I caused in the previous slides. Any questions we are ready to take? I summed it up faster so that we can finish in time. I know we are just reaching the end of the time, and you have 15 minutes for the questions.
Thank you. Thank you, Dr. Kamal Gujral. We're aware that, yes, we need a consensus somewhere along the line.
Yeah.
And I presume that we will be mature in about a year's time. when we can predict this both in the presence of a better understanding of the disease and in the presence of what we can do in terms of handling the disease.
Yeah, I
had
think American College is the most elaborate, and you can follow that guideline.
for the time being,
Those
yeah.
two is the international societies. The rest two are just the copies.
Thank you. Yeah, thank you for that insight. There are a few questions here, but before we go on to the questions, I wanted to ask if there's anybody who wants to give us an insight on whether cardiovascular malfunction in the mother is the hen or the egg. We did touch upon this briefly. And there is no doubt.
I think they came together. That's what.
Yes.
You know.
There's no doubt.
Mm.
And actually, Baski Telugnathan was the first one to tell us this, that he felt that it was poor cardiac function, diastolic and systolic, that resulted in placental ischemia, and that the placental changes were secondary to that. And then the vasoactive amines from the ischemic placenta would then result in the manifestations of the disease. And that's a very much possible condition. But it really does tell us that we have to open our mind at the moment and make sure that we use our drugs appropriately. Which brings me to all these other questions that we have received. And some of them we've discussed during the panel, but some of them we will need further inputs. And I think there is no doubt that the risk calculation is different in twins. And this is from Dr. Garima Jain. And the question is the risk calculated different in twins for PLGF? So, Chinmay, could you answer that question?
So as you rightly said, the data for twins is still yet to be validated. So as of now, PLGF norms for twins are not being calculated by validated softwares. However, we of course know that twins in itself is a high-risk pregnancy, and it substantially increases the risk of preeclampsia from around 6% background to around 30%. And thus, the prevention in the same form, the same dose, would be probably much more logical. What do you think, sir?
I think you're absolutely correct. The other thing, I think it is time now to realize that we've reached a stage where there is so much knowledge sitting out there that you and me are not able to use it on a daily basis. And what we need is an app. We need to develop an app for the diagnosis and management options in preeclampsia. It would be very, very useful where expertise and experience are not available, and where we need to have very strict criteria for deciding very simple things like aspirin versus no aspirin, what should be the referral pattern, and some of the other questions that have come along. And so may I give this task to Chinmay and our other panelists today to get together in a group and develop an app for us so that we can use this. I mean, we have the Quip app, as we know, which is a commercial app for preterm labor, but why not also develop an app which can guide those of us who are not so familiar with this disease on what we should be doing, what we should do next. So that's a task I'm giving you today, and I do hope you'll accept that.
Happy to, sir. Thank you for the opportunity.
Thank you. The next question is the role of aspirin in preventing preterm labor. Any inputs on the role of aspirin to prevent preterm labor?
So there was this pre-trial.
Yes.
So which talked about, so this was a very interesting trial which gave aspirin to all of the women before, so a non-selective aspirin, and this was actually, India was one of the sites, and this involved Belgavi also, and they gave aspirin to all of the women, and it was seen that if you give aspirin, and this was given before 12 weeks. So if you gave aspirin to all of them, there was a decrease in preterm delivery also. So now that is why, and I think sir knows it, and he also had asked me last time to talk about the great obstetric syndrome, and that's the origin. And this is why, because it's a spectrum. The all the placental pathologies, which includes preterm labor, preeclampsia, abruption, stillbirth, everything is a spectrum, and giving aspirin will affect all of it to some extent. Maximum it will affect preterm preeclampsia, but everything will be affected to a certain extent. But that doesn't mean that we give aspirin to everybody without thinking indiscriminately, we will still have to select our patients, and our best bet is do a good preeclampsia screening and give aspirin. It will have other benefits. The benefits will spill over to the other placental mediated complications.
Excellent. And then in the same breath, if you could tell us the answer to this question again from Garima Jain on whether there is a role of echo for all preeclampsia women. I know that that Dr. Navreet really highlighted this, but should we really do it for all?
So like the current preeclampsia is two different entities, early onset and late onset. Early onset is placenta mediated, late onset is heart mediated. And why I'm like sounding very confident about it, but it is a hypothesis and a pathophysiological distinction which is proposed. So it is said that if it's an early onset preeclampsia, it is more likely to be placenta mediated, and a later onset preeclampsia is supposed to be cardiac mediated. So there seems to be some logic in doing echo, but then are you doing it to establish an etiology, or are you doing it to plan management? So we need to understand why we are doing it. So if it is a mild preeclampsia, are you trying to manage it according to echo? I will not do it. But if it's a severe preeclampsia, even if it's an early onset preeclampsia, if it is helping in my management, I will do it. So we have to see why we are doing it. If I want to, try to establish an etiology, I might do it on a research basis for everybody to try and understand. But that's not for practice currently. Currently, the role of echo would be to manage my patients in women who have presented with dyspnea in patients of severe preeclampsia to rule out a cardiac dysfunction, because then I would manage it and deliver my patient suspecting a peripartum cardiomyopathy or a preeclampsia-induced pulmonary edema. I will differentiate that part. So there is my role of echo in management. So that's the whole thing.
Which brings us to this question on the role of steroids to prevent pulmonary edema. This is from Dr. Sheila Mane.
Ma'am, anybody else wants to answer? Should I go ahead?
Please go ahead. Yeah.
So there is no role.
I would agree with that currently there is just no proven role for this, and there is no evidence.
In fact, why, ma'am, I think Dr. Sheila, ma'am, I think it will precipitate pulmonary edema if we give it like that. So I would say steroids in cases of preeclampsia would be number one for pulmonary maturity, if we are planning a preterm delivery. Secondly, I would say I don't even give it for help these days. Earlier, there would be some cases where I would like to give it, thinking that it would probably improve platelet count, but controversial role. So I think my role of steroids would be for pulmonary maturity in preeclampsia. I would not worry otherwise I would not give steroids.
Excellent. And then here is a question regarding etiology and perhaps future therapeutics on the role of N-terminal B natriuretic peptide and its availability in India.
No, so this is basically a predictor of cardiac function. So basically, this has been seen to predict. So suppose a patient of preeclampsia comes to you with a possible cardiac failure, and it has been shown that this is a marker of cardiac function. So if it is, say, raised, then it is showing that your heart is not functioning properly. This is a situation where I would like to do an echo and see whether your cardiac function is okay or not, and then see whether left-sided heart failure, right-sided heart failure, left-sided cardiac failure, pulmonary edema, right-sided cardiac failure, overload. So we have to see and then probably differentiate.
Dr. Kamal Gujral, any insight onto your choice of drugs for treating hypertensive disease and severe hypertension in preeclampsia?
Well, one, I would go for the CHIP trial and the CHAP trial, that I would believe in a tight control. It does not lead to growth restriction. So my thing would be a persistent 140, 90 and above. I'll go on a low bit. Alpha-DOPA was a drug we used in the past. So this is one. And secondly, we were all talking about echo. I feel that if the profile of the patient, the phenotype of the patient, an obese woman, polycystic ovaries, and whether she has even a mild hypertension or develops a mild preeclampsia or whatever, would do an echo right from the start. I would like to evaluate her. Any woman with that profile, and which is very, very frequent in our center. So, Disney and all comes later. And if you ask them, well, yes, I do get a little breathless, but I would do for any chronic hypertension, definitely, and phenotype for me is very important. They're the ones who run into diabetes, they're the ones who run into cardiac failure. So the echo answers, and many times we have picked up a little diastolic dysfunction, and that is what.
Yes. And Dr. Panna, which direction are drugs taking in terms of this phenotype? Where would I end up using metformin? Where would I end up using esomeprazole? Where would I end up using?
To discuss in the panel, there was one nice article that the metformin, the aspirin of 20th century,
Yes, yes.
That's what you said. That,
Absolutely. So I think,
aspirin 20th
yes.
century,
So
and you
I
did
think
talk about parvestin and all those things were not available. Let's see what the future holds.
I
Metformin
think so.
works will well in, again, an obese woman who is going to develop a little bit of diabetes. If she was polycystic, she was already on metformin. I know there are controversies on continuing in the first trimester or stopping it, no harm done, you continue. They tend to do well.
Yeah.
Whether the preeclampsia develops later or not, it doesn't, no way to say. But diabetes, yes, and maybe a little bit of less weight gain, etc. So that may help the overall syndrome, nothing more than that, I would say.
Yes.
Right, right. So actually, there was this in 2022, there was
Discuss the
a consortium.
preeclampsia. This is what came into the field,
Yeah. No, because when John Hyatt tried out the same drug in the Australian group, he wasn't very impressed with the results. And so he gave up on its use in Australian Caucasians. And we're wondering whether our patients might be a completely different group when it comes
Right.
to drug response.
In late age obese women, I think metformin could be helping.
So the interesting part about metformin is that the current trials of metformin have been limited to prevention of preeclampsia in diabetic women who are taking metformin. So
they are synergistic, now both of them.
yes. So metformin has not actually been used in women purely for prevention of preeclampsia. So the hypothesis is that because it has decreased PE in women with diabetes, it is hypothesized that it will decrease. So there is much to be desired. And actually in 2022, there was a consortium where they said that there are possibly 6 drugs which were shortlisted as possible therapeutics for preeclampsia in the coming few years. And that included HCQ, and that included metformin, esomeprazole, L-arginine. L-arginine and citrulline as nitric acid donors. So this is surprising, but I think we will see a lot of research coming up in this area regarding that. And of course, we will also get a lot of newer antibodies against SFLT. So that's another line which is coming in terms of therapeutics. So there's a lot of exciting work happening in preeclampsia in the coming years and gene editing. So I think that's 10 years from now. But again, something to look
Aparna, HUKS, again, in the women who have some kind of autoimmune, that there are 10, 15 different kinds of autoimmune disease, not the real true SLE we talked about. So pregnancy losses that start there. So if you put them on HUKS in that particular group, SM positive, this positive, they have lots of the tests now. AMA, IFA, they do a lot of panel. So if you put them in HUKS, the pregnancy, blood pressure is better, so that's one group, and they are predisposed to preeclampsia. But not in all women, we can give HUKS. Let's see what the future tells us. But I think aspirin will continue to have a role. That's what I think.
But currently, there is no justification in preparing a cocktail that contains metformin,
it's only
blah, 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 and throwing it down the patient's throat and says, okay, now you will be fine. This is stuff that the future is made of, where we will not have to prescribe everything mixed up just because we heard it on a webinar, and that we really need to go to the depths before we
only
prepare
aspirin.
a cocktail prescription.
We are not giving anything.
Yes.
Yeah.
And
No,
these are all to be
What is
tested
it?
for the future and not to be used as tomorrow morning.
Yeah, absolutely.
There is a request for a repeat on the current status of ophthalmic artery Doppler, and if I may repeat that, useful at 36 weeks for perhaps we would not require uterine artery Doppler and biochemistry, useful at 22 weeks again for the same reason, and currently the 12 to 14 weeks window is under trial. Now, the last bit on the gestosis score. And I mentioned during my introduction that when we had the FIGO guidelines for restricted economies, it was taken by a lot of people in government to mean that we did not need to do anything for women in developing countries, and whatever we were doing is enough as long as we were doing something, and therefore they weren't willing to accept our preeclampsia prevention program when they were willing to do something for Down syndrome but not enough for preeclampsia. So we have to make sure that information like this is not misinterpreted. And so if we could have our words on the gestosis score. Dr. Kamal Gujral, please.
I think all women will qualify the score and be at high risk. I've tried to put every woman, 85% women, then you'll be giving them aspirins.
Yes.
So
Chinmay, yes. Chinmay,
I
you are from
FMM score that is the best, the Utinati map, etc.
That's
Just is practically every woman, and with the rising obesity what we have, every woman qualifies in natural. It's too broad a score as far as I'm concerned.
Right.
So we don't follow it. I know Foxy calls it HDP gestosis.
Yes.
When they give a HDP guideline, I don't know the opinion of others.
Chinmay, you are from the birthplace of the new gestosis program. Now, I know that whatever you say will be held against you in your city, but can you be brave enough to tell us what is your approach to the gestosis score?
I would like to know your opinion.
So I agree with you much more that we need biochemistry to have better sensitivity and predictivity. I work in a setting where I'm fortunate enough to get PAPA and PLJ for all my patients.
Yeah, we do afford.
Yeah, and when we got an opportunity, we kind of retrospectively analyzed our data of 4,000 women where we had done PAPA PLGF, and we just applied that demographics to kind of fit into gestosis. And we realized that gestosis compared to the SMF algorithm, which all of us have been using, which had sensitivity of 95% and number needed to treat is around 30 women to prevent one case of severe preeclampsia. Gestosis would have a whopping 300 women getting that treatment, and it would still miss out on 90% of the cases. So we sincerely appeal to all that PAPA and PLGF is the way forward.
Colonel Rima, in the armed forces, what was your experience? Were you able to stratify care for them?
Yes, so we did push this program forward, and we were doing this combined first trimester preeclampsia screening, where we were doing MAP, maternal characteristics, uterine artery Dopplers, and PLGF to predict women with preeclampsia. So we started it as a project, as a pilot study in the armed forces as a FMRC project, and we took it forward, extrapolated it to our clinical practice, sir.
Excellent. So there are doable ways of doing this, and we must push this as much as we can. We know that the price of vasoactive in the biochemistry variables is something that we have to bring down in the future. And we have realized with the experience we've had with NIPT that we need to push the numbers so that the industry can then cooperate with us to bring the prices down. And we sincerely hope we will all work in that direction. If there's any other input from our panelists before we close for tonight.
Rana, I'll ask you one question.
Yes, ma'am.
We do a first semester screen as we've identified,
yes.
Right? Put them on aspirin or not, whatever it is. And we do not do a second trimester SFLT with the cost issues and all that, and
Yes.
switch on to ophthalmic artery Doppler. And in the third trimester, vis-a-vis, I do the screens we've just discussed in the
Yes.
second and third. Any comment on that?
Yes.
First semester for 100%. Positives give aspirin, negatives don't give. Second trimester, just do in both the groups of ophthalmic artery Doppler, and third trimester, and skip the SFLT.
True. So we did this, and it's not just it's not that I did this, but there was the fetal medicine group from the Fetal Medicine Foundation, and of course, Velvorenin from the German group, who study the PHGF extensively. And we learned the difference between what is referred to as the linear regression model, which was our old model, that you do it once at 12 weeks and then you forget about them, compared to the competing risks model, where we add on at 22 weeks, 30 weeks, 36 weeks, and so on. There is no doubt that the detection rate goes up, and there is no doubt that the surveillance is then improved, stratified, and economical, particularly in terms of preterm delivery and postponing preterm birth. So the competing risks model is definitely here to stay because it performed much better than the initial model that we used to use at 12 weeks only. So there is now statistical evidence from the Fetal Medicine Foundation saying that we will use the competing risks model. Otherwise, it's like saying everybody who is born from a good mother will go to Harvard and join law school or medical school.
So my thing was a competing model, ophthalmic artery Doppler after the first trimester, and vis-a-vis the SFLT.
So
big difference, small difference.
Yes. So the numbers on that will be complete by next year, and we will know.
Yeah.
Yeah.
Because if it's near, then we can increase our surveillance and switch on to ophthalmic.
Yeah.
So, recently we did a thesis on this and compared both methods. So interestingly, I mean, we did have good results with ophthalmic artery. So like sir said, I mean, there are certain results that we are looking into, but we were not expecting, but I think ophthalmic artery Doppler is quite useful that way.
That's well said. You get down the cost and put more burden on the
PSV2 to PSV1 ratio with the basic concept that the same as MCA, right? So but once there is a diastolic flow, whereas there is a cerebral redistribution, the diastolic flow to the brain will increase. Similar to that, the diastolic flow to the eye will increase and the PSV2 is increased. So the ratio decreases. So similar, PSV2 to PSV1. A cutoff of 0.7, and we found the curve was so good. So we feel, and it was almost equivalent to the SFLT PLGF ratio. So definitely the numbers are going to come in head-to-head comparison. There is a lot to say because eventually in both the arms, there is no intervention. It is the monitoring that we has to be increased. So what ma'am is saying, I mean, it's something that has to make sense that there is no intervention in both arms. We are looking at monitoring frequency and the outcomes and the adverse outcome prediction. So yes, there seems to be a future in that, and we have to see. But yes, we'll be looking at it more closely. Yes.
Yeah, stratification.
So the answer will come.
There's no doubt that stratification of care in the future will be depending on maternal ophthalmic artery Doppler.
Yeah.
There's no doubt that compared to industry, people who do ultrasound of harm are exploitable in the costs. And so there is no doubt that in a nation like ours, where we have completely devoted people in imaging, we will produce great results. So I think on that very optimistic note, we come to an end of today's panel, and also on that very brilliant insight into definitions. Thank you, Dr. Gujral. Thank you to all the panelists.
And my apologies for the mess up in the beginning.
And there's not a problem at all. And Colonel Rima, thank you for coming up with this brilliant panel discussion. And thank you for the audience for being with us until so late at night. Thank you indeed. Good night.
Thank you.
Thank you, sir. Thank you, ma'am.
Thank you, sir. Good night.
Good night.
Off कर दो. इसे बंद हो जाएगा.